The next presentation will be by Dr. Timaran, Carlos Timaran, and it will be, is there a role for CAS in the presence of a carotid string sign? Carlos?
Thank you. I don't have any disclosures for this presentation. As you know, carotid stenting is an alternative for the treatment of carotid stenosis, particularly in high-risk patients. What we need to also understand is that there are some high-risk lesions for carotid stenting, and those usually occur in patients who are octogenarians, have an unfavorable aortic arch, angulated carotids, and unfavorable lesions. Now, is carotid string sign an unfavorable lesion and therefore a contraindication for carotid stenting? This is what we're trying to answer with this combined experience from our center in the Santa Casa University Hospital in Brazil. This is a case that we did perform recently. 62-year-old patient had prior percutaneous coronary intervention with a drug-eluting stent. Patient had a right hemispheric TIA. The MRI revealed a right cerebral acute infarction, and then duplex and near occlusive lesion of the right internal carotid artery. This is the diagnostic angiogram that reveals the severe stenosis and underfilling of the distal ICA consistent with a string sign. In that particular case, we decided to use a microcatheter and cross the lesion to make sure that the ICA was patent and did expand. And more importantly, we wanted to assess if that ICA reached the distal circulation, which it did, as you can see here. So we performed a carotid stenting. For this particular case, we use embolic protection with the cord flow reversal system. And you can see the two balloons, the one in the common carotid and the one in the sternal carotid, and we're deploying the stent under embolic protection. Obviously, there was not a problem crossing the lesion because only a small 014 wire was used to, again, cross the lesion. And as this angiogram shows, everything was done under flow reversal. So these are the angiograms, and this is the completion angiogram that reveals excellent result with good distal perfusion of the intracranial circulation. You could see now the anterior cerebral artery patent. We checked the filter that's between the artery and the vein, and this is what we found at the end of the procedure. So we reviewed experience, as I said, in 2 centers. 13 patients underwent carotid stenting for carotid string sign. 62% of the patients were symptomatic. The indications included severe comorbidities in 44%, hostile neck in 23%, high or low lesion in 19%, contralateral occlusion in 14%. In 4 cases, the initial 4, a filter was used, and in those cases, predilatation without a filter was necessary in 2 cases. Therefore, we switched to proximal embolic protection with the MOMA device, which was used in 8 cases, and the Gord neuroprotection system, which was used in 1 case. Technical success was 100%. After balloon angioplasty, a normal caliber ICA beyond the lesion was seen angiographically in all cases. There was no strokes or deaths. There was no TIAs or documented MIs. Only 1 patient had 1 growing hematoma. 2 patients died at 12 and 24 months for reasons unrelated to their carotid lesions. There was 1 stent thrombosis 6 months after the carotid stenting procedure. There was no stent restenosis or ipsilateral stroke during the follow-up. So in conclusion, carotid string sign may be treated with carotid stenting with favorable periprocedural and early results. Because of the frequent need of predilatation and possible inability to advance a filter device without previous unprotected predilatation, either proximal balloon occlusion or flow reversal devices may be favored, as this may effectively provide cerebral embolic protection throughout the entire carotid stenting procedure. Thank you.
Thank you very much.